health care reform. And we have speakers today, Eyre of KTP Advisors, and Jay Condon, who's the Chief Financial Officer for Brockton, Massachusetts.
Well, thank you very much for the introduction, and I really appreciate the opportunity to be here and speak with you on what I think is a pretty relevant topic for most municipalities, not only in New England, but around the country. So, again, I'm Eyre, the company is KTP Advisors, and obviously Mr. Condon is well known by a lot of you. So, just getting into what we're going to do is we're going to talk a little bit about the legal framework in Massachusetts and some recent changes that have happened to help facilitate changes related to retiree health care, some of the specifics of the situation in Brockton, and then we're going to go into kind of the strategy that we employ in Brockton to help reduce the cost of retiree health care. Here we're talking about Medicare eligible retiree health care and how those strategies can work, and they are applicable to not just Massachusetts, around the country. And then some of the issues that you could face when thinking about an RFP and structuring it and understanding what benefits it is that you're actually providing, because this can be a tricky point, particularly with collectively bargained agreements. A lot of the things that are in collectively bargained agreements don't necessarily match up with what's available under Medicare, so you have to be very careful about how you structure your RFP. We'll talk a little bit about the specifics of Brockton, the outcomes, another example from around Massachusetts, and then get into some other things about jurisdictional issues and knock-on effects for reduction of OPEB liability, because there are some important bonuses from approaching reduction of costs the way we're going to talk about doing it today. So the first section here is going to be spoken about by Jay. We talk about Massachusetts and Brockton. So,
blocking the, can you all see the slides behind me? Can you all see those? I guess so. Okay. In Brockton, we ended up saving well over $2 million by the, and that's net savings because the city was self-insured fully self-insured for all its health insurance, and that was net of the Medicaid subsidy we have in Medicare Part D, and so it was a substantial savings, net savings for $2.5 million. Most of you who are in Massachusetts would know that prior to a couple of years ago, when there was some health insurance reform legislation passed, there were really most of the changes in Massachusetts health insurance were focused on the share of the cost between the employer and the actives. It was almost impossible to bargain benefit changes union by union. You couldn't have separate plans for each union. So almost all of the plans were focused on basically what share of the cost is split between the union and the employer. When I got in Brockton many years ago, the city was paying I think $44 a month for the old Blue Cross Blue Shield Master Medical Family coverage and $16 for the individual coverage per month, and the same dollar payment was being applied toward the HMO. So basically the HMOs for the employees were free, and they were paying about $500 a year for the health coverage if they're in the Master Medical Plan. So over the years we bargained union by union, year by year, contract by contract, and finally got those savings up to about 25% for the employee contribution for the plans. It was a substantial amount of savings, but you're paying for that with usually with wage increases. The other opportunity in Massachusetts before the old structure, before the new health legislation was passed, was a section of the statute that allowed you to do coalition bargaining. It wasn't widely used for a couple of reasons. For one reason, it gave the retirees a participation in the coalition, and they otherwise didn't have any right to bargain collectively over their health insurance. So a lot of employers, municipal employers, weren't eager to put the retirees at the health insurance bargaining table in a formal way. Another reason it was resisted was that it was bargaining over health insurance alone, and most employers weren't eager to divorce the wage bargaining from the health insurance bargaining, because the health was mostly usually the most expensive benefit. It was a cumbersome structure as well, because it provided for a very formal structure with a weighted vote for the coalition, 10% of the retirees, and then each union by a percentage of the total membership was granted a vote. So it wasn't widely used. I know there were a couple of communities that did it. So a couple of years ago, there was a move to move the municipal health insurance cost in a different direction, and amendments to Chapter 32B, which is the health insurance legislation of Massachusetts, were passed. And it provided for kind of a truncated kind of coalition bargaining opportunity where you could either accept the statute, and if you enjoyed certain kind of cost savings by going to the Group Insurance Commission, the Massachusetts state agency which provides health insurance for state employees in some municipalities. If you achieved a certain level of savings from your current plans by going to that, you could go into the GIC, or you could use the GIC plans as a benchmark if you weren't going to achieve enough savings by going to the GIC, and set up new plans which mirrored them and maybe would save something close to the same amount of money. This bargaining structure had, as I said, it had a coalition element to it, and it really wasn't collective bargaining as most unions would have regarded it, because there was really no right to bargain over whether you were going to implement this or not. The decision by the city council or town meeting would have implemented it, and the only bargaining was really over the impact on some of the members if they were disproportionately affected. So the unions weren't too crazy about it. So the city of Brockton, we were looking to save some money. Would have been about $7 million for the city to have accepted this legislation. So a little over a year ago, we did our studies about a year and a half ago, and a little over a year ago, we took the health reform legislation to the city council and asked them to accept it so that we could implement it and save about $7 million. City council has 11 members, and we got 0 votes for our proposal. It's a heavily unionized city. It was one of the only communities in all of Massachusetts which took this opportunity to its legislative body for a vote and had the body say no. And in our case, it was a pretty resounding no. It was the evening of this discussion, there were union members lining the hallway going into council chambers and city hall, screaming and yelling and stomping and chanting. And when we get into the council chambers, and it was about a two-hour discussion and back and forth, the discussion got pretty heated, but the members of the city council were committed that the unions should not have had the collective bargaining rights impeded as the section would have done, and that was their basic decision. And at that discussion that night, several union members, including the firefighters and those of you in Massachusetts, usually the firefighters and the teachers are the toughest to deal with. Well, the presidents of those 2 unions actually made a commitment publicly. We will bargain with the city over health insurance to try to save something which would have been saved by this approach. So we took them at their word, and months passed. Nothing happened. So the mayor sent a lot of public aid, and finally that brought them to the table, and we actually did enter into collective bargaining. We pretended that we'd accepted Section 19, so it was coalition bargaining, on the premise that if we get to an agreement, we will accept Section 19, and that's basically what we did. We got to a Section 19 kind of agreement. It was not as strong a savings for the city of Brockton as it would have been had we done coalition, or rather the new health insurance reform legislation, but it came close. The reason it came close was we gave the unions the option. Their original proposals were not to touch the Medicare eligible retirees, to raise their co-pays, not have annual deductibles, but they were still looking for a flat co-pay. We went back and forth, back and forth, back and forth, and finally came to an agreement where we didn't gain annual deductibles, but we got substantial increases in the co-pays. We got them tiered depending upon the kind of service being offered, and that saved us a fair amount of money. And we gave them an option, which was to implement that kind of a plan for their retiree base, which meant that they would have been seeing more out-of-pocket cost, or to allow us to bid out the health insurance for the Medicare eligible retirees on a fully insured basis as opposed to a self-insured basis. We engaged Barry's firm, KTP, to do it. And the end result was, as I said at the beginning, we saved about $2 million and change, 2.45 million, something like that. After reducing or eliminating the value to the city as a self-insured entity of the Medicare subsidy for maintaining the Medicare Part D drugs. So that's basically where we are. And I'll turn it over to Barry to to finish the presentation on the specifics of it. The only point I'd want to emphasize is that we came close to the final savings that we would have achieved on the GIC approach, although it was somewhat delayed because of the collective bargaining, only because the unions decided to allow us to do this competitive bid for the Medicare eligible retirees, and the savings were more than we would have gained had we gone into the GIC type plans.
Okay, so I'm going to just go into a little bit now about the approach, the strategy that we employed. If anybody has any questions during this presentation, I'll also take questions at the end, but as we're going through it, if you'd like me to stop and talk about a particular point a little bit more, I'm very happy to do that. So one of the things to realize about your approach to your Medicare eligible retiree health care is that it's fundamentally different than your active employee health care. For active employee health care, the local providers have usually signed up networks of doctors and hospitals and negotiated rates with those doctors and hospitals. The goal being that they're going to use their clout in the marketplace to get better pricing, which they're going to pass along to plan sponsors. So having those local connections is important and gives them a competitive advantage. Somebody from out of the marketplace does not have that, the local market does not have that same advantage. Now, if you compare that to the Medicare world, it's completely different because Medicare, as you're aware, is a federal program. Most doctors take Medicare, and so any insurance company that provides a Medicare supplement plan, as long as they're approved by CMS, the Centers for Medicare and Medicaid Services, can offer insurance through those same doctors. So the advantage of a network that a local provider has completely goes away in the Medicare world. Now this is really important because it expands the number of providers that you can go to when you're running an RFP. Obviously more competition generally results in a lower price. And another thing that's really important from the retiree's perspective is that you don't have any disruption, because even though the provider might change, they're going to be able to stick with the same doctors and hospitals that they've been going to for years and years and years. And that's one of the critical components of resistance to change, obviously, is fear on the part of retirees that they may need to change their doctor and hospital. There's still a big issue, obviously, around the local providers like the Blues represent healthcare in the minds of retirees and also active employees as well. But when it comes to the retiree component, they're not going to have to change. The name on the card might change, but they can still go to the same doctors and hospitals, and you've got an expanded set of providers that can bid on your business. So the next component of how we achieve savings is the idea of maximizing federal subsidies under Medicare, and this is critically important. So most municipalities and also plan sponsors generally, like corporations, unions, have over the last few years on the Part D component, the drug component, been accessing a federal subsidy that's called the Retiree Drug Subsidy. And the way the Retiree Drug Subsidy works is it's a spend money to get money back proposition. So you, as a provider, as a plan sponsor, would track the drug spend of individual retirees. And there's two thresholds, about $350 and about $6,500. So between those two thresholds, you're allowed to get back 28% of that spend. So you track through the entire course of the year all the spend by all your retirees. At the end of the year, there's a reconciliation process that goes on. You make an application to CMS, and 6 months up to a year later, you would be able to get back 28% of that spend. The piece of legislation that created the Retiree Drug Subsidy, which went into effect in 2006, also created another pathway for subsidy under Part D, and that was called the Employer Group Waiver Plan. Now, the Employer Group Waiver Plan is more arcane and more buried in the legislation, so it was not really picked up on by most advisors or by most plan sponsors initially. So, however, it has been available for quite some time. And it's fundamentally different than the way the Retiree Drug Subsidy works. There's two components to the Employer Group Waiver Plan. The first is that there is a base level of subsidy. Switching back a second for the Retiree Drug Subsidy, on average across the entire country, if you look at the amount of subsidy that most plan sponsors get, it averages out to around $500, $510 per retiree per year. And that's pretty much in line with Brockton's experience and most mass municipalities that we've spoken to. On the employer group waiver plan, you also get a base subsidy, but it's not dependent upon the amount of money that you spend. You also don't have to wait until the end of the year, until well after the end of the year to get it. It's risk weighted according to the, the health of your population. But again, on average across the entire country, the base subsidy is well over $600. So right from the beginning, you've got a better subsidy going on with the employer group waiver plan. Now, I mentioned about the timing. With the RDS, you have to wait 6 months. Sometimes I've heard as much as 12 months after the year because of the reconciliation process. But with the employer group waiver plan, if you're using a fully insured solution, the provider, the insurance company, will be able to look at your population. They'll understand what your subsidy is going to be, and they'll be able to bake that into your premium. So you're going to experience a lower premium from day one. So not only is it going to be a better subsidy, but you're going to have a cash flow advantage in that you're not paying out as much from the beginning. So the retiree drug subsidy, you pay out more, you wait, you get some money back to offset your costs. With the employer group waiver plan, your costs are actually lower on an ongoing basis through the course of the year. So the other component of the employer group waiver plan, which is completely absent from the retiree drug subsidy, is what we refer to as the catastrophic reinsurance. So there's a threshold under the employer group waiver plan, above which, on an individual basis, if a retiree has a drug spend over $6,700, and these numbers are all indexed according to CMS every year, so these numbers do change a little bit, but once you get beyond that $6,700 level, you can get back 80% of the spend on drug spend for an individual. So if you had a retiree that had $20,000 drug spend, if you were in the RDS, once you hit that $6,500 threshold, you're completely on your own as a self-funded plan sponsor. So you have to pay 100% of the cost above that level. With the employer group waiver plan, you're going to get back $20,000 minus the $6,700. You get 80% of that money back. So obviously this is a very significant additional benefit from the employer group waiver plan, which again would get baked into the premium. Now, this is even more important because of what's been happening in the pharmaceutical industry over the last few years, and will be continuing to go on over the, for the foreseeable future. Probably the thing that people are most aware of that's gone on in pharmaceuticals has been this huge movement of brand drugs losing patent protection and going generic. The most famous example, obviously, is Lipitor, which has recently lost patent protection. You can now get generic versions of it. So there's been approximately, over the last 3 years and continuing for the next couple of years, approximately $80 billion of annual spend in pharmaceuticals that lost patent protection and gone generic. Obviously, this is great for plan sponsors. You'd be able to provide generics instead of these expensive brands. That's great. But at the same time, the pharmaceutical companies have been pouring money into research and development for what is referred to as specialty pharmaceuticals. So these are very, very specifically targeted drugs. They will particular types of cancer, MS, a lot of different highly targeted things. So not a large population of people that would be able to that would benefit from these drugs. But if they are members of your population and they are prescribed one of these drugs, the amount of money can be phenomenal. And we're talking, some of these drugs are up to hundreds of thousands of dollars a year. So going back to thinking about the structure of the RDS versus the employer group waiver plan, with the RDS, if you had somebody who was prescribed a drug that was $100,000, the maximum subsidy you can get is the $1,700 in this chart here. So that's the difference between the $350 and $6,500, 28% of that. So with the employer group waiver plan, though, you would get 80% of everything above $6,700. And although you may or may not have experienced anybody within your population being prescribed one of these drugs yet, there are approximately 800 of these drugs in the pipeline at the FDA right now. They're going to be more and more prevalent going forward. Currently, I think nationally, there's about 25% of drug spend is related to these drugs. It's only driven by about 1% of the population being prescribed the drugs. And it's projected that within the next couple of years, these drugs are going to account for fully 40% of the entire drug spend in the country. So even if you haven't experienced it yet, you are likely to experience it, highly likely. And continuing with the RDS provides no protection to that. So this is another reason why it's very, the huge benefit going forward for the employer group waiver plan. So now talking a little bit about the practical aspects of how you would actually implement one of this strategy. Like if you wanted to use an employer group waiver plan and use the fact that competition can drive down prices. When you look at your benefit that you're offering to your retirees, obviously there's a medical benefit and there's a drug benefit. So it's possible to fully insure just the drug benefit, and you would get significant savings from doing that. On average, we estimate that the savings from just doing the employer group waiver plan is approximately $80 per member per month. So a pretty significant amount of savings. But if you think about the way that a self-funded plan works, which a lot of municipalities are self-funded, as was Brockton previously, when you're self-funded, you're actually, you're paying an administrative fee to either a third-party administrator or a health plan to basically process the payments for you. So if you go ahead and split the benefit and just fully insure the drug component and stay self-funded on the medical, which is a strategy that's just sometimes implemented, you would continue to pay the administrative fees on the medical side. And those can be as much as like $25. I mean, they've come down a lot. They used to be like $100 per person per month. I think $25 is more of a typical amount right now. But a big chunk of your savings that you're going to get out of the employer waiver plan, that $80, would then be used to continue to pay the administrative fees on the medical side. And you would also continue to be exposed to the risk of larger claims on the medical side. So by combining both of them and going out to bid for a fully insured plan that does both the drug and the medical, you completely eliminate all those administrative fees, and you would enjoy the full savings from the employer group waiver plan. So in our opinion, the best strategy if you want to move forward with taking advantage of the employer group waiver plan is to do a fully insured solution for both the drug and the medical benefit. So what does it mean to actually go into the process of doing this? And this is kind of there are some important nuances to how you would run an RFP, and some of this stuff came up in Brockton as well. The RDS, in order to get the RDS payments, you have to have a Part D compliant formulary. Formulary is the list of drugs that you provide, and the Center for Medicare and Medicaid Services has this formulary, and you have to cover at least that formulary. There are other drugs which are not covered under that formulary. And it's the same thing with the employer group waiver plan. So, but a lot of collectively bargained agreements cover drugs which are not part of the Medicare formulary. So in order to make sure that you are not having disruption, or that you're still being compliant with your contract with your unions, you need to make sure that you're continuing to cover those drugs. So it's possible to make a rider or some additional drugs that will be covered. You would not end up getting the subsidies that are available under the employer group waiver plan for those classes of drugs. But if you're covering them now and you're getting the RDS, you're not getting the RDS for those drugs either. It's just important that when you go out to bid and you're telling the providers what your drug plan is, that you specifically say, I don't just want an employer group waiver plan, I want to make sure that I'm also covering all these other drugs. So that's an important thing. Another issue is the issue of the tiering of drugs under your current formulary versus what another provider might have. Oftentimes there are tiers that affect the level of the copays that the retiree will receive. Not all insurance companies are going to have the exact same tiering. So it's important to do a disruption analysis where you look at what the actual drug spend was previously, how the copays worked, and if we implement a new plan, what those changes are, because none of them are going to match up exactly if you switch to a new vendor. I mean, it could be very close, but at least you would understand the level of disruption and you'd be able to plan for it. Another issue that comes up, again, this was an issue in Brockton, is in order to do a fully insured plan, ideally you will go down to one plan. And that stops the problem of adverse selection. Because if you have two plans, one that's very rich and one that's like a light plan, those people that are healthy are all going to choose the light plan. The sick people are going to go into the expensive plan, and it's going to drive up costs. So ideally, the insurance company is going to want you to migrate to a single plan. Now, if you have multiple plans, though, that would mean, even if you said, well, and it's quite possible, this is what we did at Brockton, you could say, well, we'll look and we're going to match the benefits of the plan that's got the most people in it. You know, that will provide the least amount of disruption. But those other people who are migrating to the new plan will experience disruption. So understand exactly the differences between the two plans or multiple plans and what the impact are going to be on the retirees is very important, again, in terms of managing the expectation of retirees and also for you as managers to understand what the impact is going to be on the population. Another important point too, you know, HMOs, and there are certain other plans which are cheaper in terms of like the cost, but may have significantly higher out-of-pockets as you go through the year as a retiree. So it's not necessarily true that if the premium that the if the premium goes up on the plan and their out-of-pocket on a monthly basis goes up in terms of their cost share, that their net cost at the end of the year is going to be higher because the new plan may have lower copays for doctor visits, emergency room, drug copays, things along those lines. So understanding that dynamic is important, again, in terms of managing the disruption and communication with your retirees. Getting back specifically to this example of Brockton, I don't know if you want to talk about it. So Brockton's premium equivalent rate, so basically taking all the claims and dividing them by the number of people, they're paying approximately $480 per person per month. Brockton was participating in the retiree drug subsidy, which we spoke about previously, and that was about $47 a month. So they were netting down to about $435. After this process, where we had competitive bidding, more providers come in, readjusting the subsidy program, we were able to come up with a fully insured product, which matched the most popular, and actually which was a higher benefit generally in terms of levels of copays, for only $330 on a fully insured basis. So previously, Brockton was effectively self-insuring, completely exposed to the risk of large claims. Now, after subsidy, saving $100 per person per month, and they've completely shifted the risk over to the insurance company. So, I mean, it's a pretty significant amount of savings. The interesting thing is that initially, the incumbent provider, Blue Cross, was not part of the bidding process when we came up with bids, went into collective bargaining. The unions asked us to include Blue Cross in the bidding again, and Blue Cross was able to come back and match the previous bid. So they dropped their price from $480 on a self-funded basis to $330 fully insured. And Blue Cross is now still the provider. But, you know, the city's saving 25%. Sorry, go ahead.
I have a question on that. Now, is, you know, when you're saying about the RDS and everything, who actually does that paperwork for Brockton? Does if you give it to Blue Cross, are they going ahead and applying for the RDS and the other, you know, supplements?
Right. Well, so one of the great benefits, in terms of like the RDS, there is a huge amount of paperwork to do. It can either be done by the plan sponsor, it can be done by the advisor, or it could be done by the insurance company. So, you know, there are resources and costs to doing that. You're either going to pay your own HR department to do it, or you're going to be paying an insurance company. It's going to be into your premium. So, you know, I know previously, what did Brockton do on the RDS?
Company, our claims monitoring company did that for us.
Okay, so they had a third-party vendor who was doing that for them. Now, with the employer waiver plan, the way the employer waiver plan works is an insurance company is matched up with a PBM, a pharmacy benefits manager, like an Express Scripts, CVS Caremark, someone along those lines. That company will have the contract with CMS, Center for Medicare and Medicaid Services, and they actually are required to put in for all the subsidy payments. So they take care of that in the background. So you no longer have to do that from an administrative perspective or pay somebody that's third party to do it for you. So that's another benefit in terms of like reducing the cost for you. But on the RDS side, somebody is doing it and it's quite cumbersome. I mean, as you can imagine, you're tracking the drug spend for every single one of your retirees. There's a reconciliation process, it has to go to the federal government, sometimes it has to go back and forth. You know, there's a lot of work there. But that completely is eliminated when you switch over to the employer waiver plan.
If Brockton had gone into the GIC, would all of this be shifted to the GIC so it just wouldn't be an issue for you?
Yeah, we'd just be priced acres. Priced acres. GIC sets the plan, sets the price, and we just pay.
Have they gone into this?
The GIC does not offer any employer group waiver plans at the moment. The OPEB Commission report, which came out in January, specifically directed the GIC to examine starting some employer waiver plans starting in 2014 or 2015. So effectively, they've given the nod to say, yeah, this is a good thing, but it has not been done and is not available yet. So, and again, it's kind of like this holistic approach too. If you went into the GIC but you had a standalone, fully insured employer waiver plan, or you could do it self-funded, you may not be getting the full benefit if you're continuing to pay the admin fees on the medical side. So, you know, from our perspective, looking at a lot of what goes on in GIC, the savings are a large part cost shifting onto retirees or active employees. So, you know, right now it is not available. So I don't know exactly what the structure would have looked like. I mean, the savings that would have been achieved would have not been because costs were reduced significantly or Brockton had gone in. It would have been because the retirees and the actives were paying more.
That's right.
So this is a more palatable solution in terms of like relationships with your retirees. And
Al, over the years I had a lot of conversations with folks in the GIC, and their contention was always that because of the size of the groups that they were purchasing for, they had contracting power that allowed them to gain savings. I was never able to really determine how true that statement was. I mean, intellectually you could say I could see the argument, but it always looked to me like the bulk of the savings was going to be basically the same as a cost shift. You know, you're paying, as an employee or a retiree, you're paying more out of pocket, and that's where the savings comes from.
Right.
It could be they just don't want to go through the tremendous amount of paperwork with such a large group. Could be.
Well, but you know, the thing is, right now they're getting the RDS, which is a lot more paperwork. So they're devoting all those resources that I was talking about in terms of like tracking the costs and doing the submission to the CMS and the reconciliation. They're doing all that now. If they moved everybody into an employer waiver plan, they would have the same benefit of reduced administrative burden. So I think it would actually be easier for them and more effective from an administrative standpoint to do it, but it just hasn't been embraced. I mean, I think, you know, I'm not sure why. And to the point about like the size of the group, you know, some of the providers of Medicare supplement plans that we're talking about here have got hundreds of thousands of Medicare eligible lives, and so when they're not necessarily doing group by group pricing. You know, the 2,000 lives or 500 lives that come into a pool of 300,000 or 400,000 lives doesn't really affect the pricing of the group. And so there are definitely insurance companies that we work with that they don't even require claims because their group is so big. So, and so that's like they have even more retirees than the group insurance commission. So even though you've got a small group, you might be going into a pool that dwarfs even the size of the GIC when you're dealing with some of these national players. Is there another question?
Comment on this. What I heard for the GIC with reluctance for EGWP is that right now the GIC retiree plans are fiscal year and EGWP plans have to be calendar year.
Yeah, you know, I mean, this is true. The subsidies under Medicare run on the calendar year basis. But you know, the fact that most municipal retiree plans run on a fiscal year base, the fiscal year of the municipality, which usually maybe starts in the 7/1, is problematic from the retirees and also from the human resources departments because you have two sets of communications as well. You would have open enrollment for the plans prior to 7/1, but then you have a whole other set of communications that goes on to the retirees because of all the setting of levels of copays and things along those lines from CMS that happen in the fall. So you have another set of communications. So moving your retiree plans onto a calendar year basis, which is what happened in Brockton, actually is going to reduce the administrative burden on the human resources department. So, you know, while that may be true, it's certainly something that can be worked around and is to the benefit of the plan sponsor and also the retirees as well, because they're not getting more and more, there's two sets of communications during the course of a year. So this was, again, the difference between the savings for the city and the retirees was the fact that because the city had to give up the retiree drug subsidy and the retirees were not participating in that, the savings to the city were less after netting out the retiree drug subsidy. So obviously this is a one-year example. We've got a great savings, huge number going down for Brockton. I'm confident that, with proper management, that renewals can be under control going forward. However, as an example of a history of another client in Massachusetts, we've been working with Greenfield, Massachusetts, since 2006. If you remember, I said before, the employer group waiver plan was created with the same piece of legislation that created the retiree drug subsidy. So Greenfield was in a similar Blue Cross plan to Brockton back in 2006. We moved them into an employer group waiver plan the first time it became available. Big reduction in cost. Now, over the intervening years, there have been changes, nuances in the way an employer group waiver plan has been structured, which, if you took advantage of them, would continue to reduce your cost. So if you're really focused on what's going on with the structure of the subsidies, you can continue to benefit from changes. Additionally, during this intervening period of time, a problem in terms of keeping things under control in terms of price is that the incumbent provider gets kind of comfortable that they're going to continue to get the business because of a lack of going out to bid on a regular basis, and the renewal rates start to creep up. So you have to be prepared to go out to bid to keep them honest. And during this period of time, Greenfield did go out to bid and replace their carrier because they had a renewal that we found unacceptable. So I guess the message here is that even though the employer, this is a great story right now, day one for Brockton, we have examples where it's been working for a longer period of time. And the renewal rate during this period here is minus 2.4%, and that's for drug and medical combined. So the employer group waiver plan has been out there for a long time. It's just that, I don't know how often you've heard about it before, but, people have been benefiting from it for quite some period of time.
Isn't it all dependent upon the continuation of the Medicare subsidies, though? That's got to be vulnerable in the climate in Washington.
Well, I mean, what I would say is that both plans will be affected by Medicare subsidies equally. Right now, today, the employer group waiver plan is far superior to the RDS. Make hay while the sun shines. I mean, I don't know, is it going to last another 2 years? Is it going to last another decade? But if you can save 20% per year, take advantage of it while you can. And also make sure that you have somebody who's monitoring what's going on. So if there's another program that comes up, that you take advantage of that when it comes up as well. Because one of the things which is constant is the fact that these things change. I mean, there's been a huge amount of changes in legislation related to retirees during this period of time. Affordable Care Act does not really affect retirees directly. They're not going to be going on to the exchanges. But, you could probably expect that, the changes in there's proposed changes in Medicare. Depending upon how they look, they may or may not affect these subsidies. They may create another subsidy. But all I'm saying is you have to be monitoring the stuff going forward to take advantage of the changes as they come along. One last point, I think this is really important in terms of an advantage of the employer group waiver plan over the RDS. Because the RDS money comes in the form of a check, it goes directly into the general fund. It does not specifically reduce the cost of health care. That money can be used for anything. When an actuary calculates your OPEB liability under GASB 45, they're not allowed to use that money to offset the future cost of your health care. Now, the employer waiver plan is actually reducing the cost of the health care, so your trend is lower. So when they do the actuarial evaluation, they build in the fact that you're an employer waiver plan, and you can actually is a big reduction in your OPEB liability. In fact, the state of Connecticut, about 2 years ago, switched from RDS to an employer waiver plan, and their actuary attributed a $5 billion reduction, and it was about $25 billion OPEB liability, specifically to the switch from the RDS to the employer group waiver plan. So obviously, we have, this has an effect on bond ratings. There's all kinds of positive benefits from your OPEB liability going down. So not only are you going to be reducing your cash out-of-pocket costs if you go into the employer group waiver plan, but you would actually be very helpful for your balance sheet by reducing your OPEB liability as well. So obviously this is a New England Government Finance Officers Association meeting. We talked a lot about Massachusetts. As I said before, Medicare is a federal program. The RDS and the employer group waiver plan can be done in any state in the country. So, and also there are multiple bidders that are available. You know, you don't have to continue to go with your incumbent. So it's, this type of strategy can be employed anywhere in New England. This is kind of something I talked about a little bit before, the fact of why you want to do bidding. I mean, in most New England states, and this is not just in New England, there's huge market concentration in terms of the providers in healthcare. The top 2 providers have got, you know, as you can see here, anywhere from 66 up to 90% market concentration. So if you're not actively bidding out your healthcare and you have really high market concentration, that is a recipe for complacency on the part of the provider, not sharpening their pencils, not fighting for the business, and prices going up. If you want to control the cost of healthcare, you have to inject competition. You have to make sure you're employing best practices. You understand that you're asking your providers to give you the right thing. And I think if you do that, you're likely to see some very favorable results in terms of the renewal rates that you experience. Brockton and Greenfield as 2 specific examples. So that's pretty much it for me. If there's any further questions, either of us. Good, thank you very much.
Thank you, gentlemen. We did have, the conference center did move up lunch for us. It will be available